Thank you and good evening, Professor Namrata Sharma and Professor Rajesh Sinha. And I also like to thank AIOS and ZEISS for arranging such a nice webinar. Am I visible?
Perfect, perfect. Everything is fine.
Thank you. Um, so we have got this very recently, and we were eagerly waiting to use it. And as with new technology, this is just a journey, and this was a very good journey for us. We were waiting for it for a long time, and for any technology, it goes through adaptation. And what used to happen is that we used to get all these technologies once they were tested in the Western countries. We used to get it after many years, third generation or fourth generation, and we used to get all the benefits. But now scenario is changing, and we nearly order at the same time. So we are also going through the evolution and contributing to science. So why we wanted this microscope? As Professor Sri Ganesh says, is that, what you see better, you can operate better. So viewing, one thing is that we wanted to see is clarity, the ergonomics, that we were all talking regarding how we had to sit straight with our uh, back straight and our eyes fixed to the oculars for a prolonged time, causing neck and back pain. And the beautiful magnification that it goes up to, and we are also talking regarding
I think we've lost audio from Dr. Anwar. Is the audio on?
No, ma'am, the audio is off.
Now, the Dr. Anwar, can you repeat? Dr. Anwar, can you write it on the chat, Sudhil, that there is some
hello,
problem with the audio?
am I
Now,
Hello?
audible?
yeah,
Yes,
now you are audible.
Okay. So better depth perception and all the informations that we has used to have in Callisto, like what the illumination, the magnification, what mode we were using, and this is an excellent technique teaching tool. So all the OR staff and the fellows can see whatever we are doing. So our experience, we had a big expectation, and when I saw first, it was just wow, that such big images that we can see with such clarity. But with time, we had to adjust some of the OR settings and how we were doing our operations. So this is a big screen, 55-inch monitor, and there is possible to go with huge magnification. It looks so big, the eye, and the illumination, as the previous speakers has said, that it can be as low as 5% of what we used to do. Like here, what we can see that the magnification is nearly 20 times. Still, there is no distortion of image, and the depth perception is very nice. So the learning curve, when we were getting it, every surgeon of our hospital was very eager to know that how it's going to be, how hard it's going to be adapt. And we had a live surgery just 3 days after we got it. And I had the opportunity to do one of the live surgeries. So I did just 2 surgeries before that day. And it was not that problematic. I could do a live surgery with a normal speed. And the other things were that where to set the monitor, how to sit, how much to tilt the head. All these things, I think, with 3 to 5 surgeries, it is possible to get idea and get accustomed to that. So the learning curve, I would say that it's not that much. And as the previous speakers have said, that we can do surgery in very low light. So there is less chance of phototoxicity, especially when the trainees are doing, they tend to take more time. The patient comfort is much more, and nearly it can be done at 1/3 of the light what we were used to do. The magnification is enhanced. The depth perception is not that much affected when we magnify it. And the resolution, as it has been mentioned, that is a 4K quality, beautiful resolution. I would like to just share two surgeries. At, we can see that the magnification and all the add-ons here, how much illumination. I was initially using little bit more illumination. So this is a lens I intended to do was a bag in the lens. So once the anterior capsular axis was done, we have to do the posterior capsular axis. And we can see beautifully even the wrinkling of the posterior capsular axis. So a nick is made with a lateral movement, and then with OVD that is enlarged, and the OVD is pushed into the Burger space, separating the posterior capsule. And all this was visible so beautifully. Then a posterior capsular axis was made, in the similar size of that of the anterior capsular axis. Just for the sake of time, I would just go little faster. This is edited. Once the posterior capsular axis was made, this is a special lens, Bill IOL, which was invented by Professor Mare Jose Tazignon. So we put both the capsular axis rim in the groove of the IOL. And we can see both the anterior capsular axis, posterior capsular axis, everything so clearly, and look at all the surroundings. And even up to 25%, 20 times magnification, it was so nice. And as Professor Titil was saying that in PCT or other cases like this was one of my colleagues was doing this case where he intended to put a toric IOL and there was a posterior capsule rupture. So I took over and converted that rupture into a PCC. So this was a toric IOL intended. And what I would like to say that the magnification is 10 times, illumination is 45%. I could see the anterior capsular axis, posterior capsular axis, and place the lens in between those two. And as Professor Titiwal was saying that we have a beautiful 3 lines which guides us where to put and place the intended axis. So just dial it and put them in that axis. So you can see that anterior capsular axis and the posterior capsular rent margin so nicely. It's so clear and visible even with that magnification. So when we got it, there was some apprehension regarding the latency, but as discussed earlier, it's only 50 microsecond, which is nothing that our brain can detect. So it's seamlessly, we can go along with normal thing. And the other thing is that there is something that Zeiss is calling hybrid mode, that we can put the ocular at any moment. If we are not comfortable and we feel that we need to use it, it's very easy. It does not take much of time. It takes only 30 seconds. You have to just screw it and we can use both the ocular and the monitor is also there. So all the OR stuff can see whatever we are seeing through the ocular. But there are some little adjustment we had to make, as most of the surgeons now operate temporally. So for a right eye and left eye, the screen needs to be constantly moved and rotated. And we can't view exactly straight ahead, which we're doing till now. So this needs to be adjusted, and we have to tilt little bit to the right or left according to the eye. And I was trying to go close to the microscope, but I think as Professor Sri Ganesh said, that if we lean back a little bit, this would not create problems. So this was a good tip for me. I'm going to try the next day. So this is the thing what I felt, that lot of movement of the monitor was needed once I was going from left to right side, and there were so many wires, thick wires, and at times I felt this could be an issue with the sterilization. It can touch the trolley or something. So for maintaining an optimal viewing, adequate distance is required. It says that 5 to 6 feet. So we have to have a big OT for this. If there is a small OT and somebody operates, then this can be a point. And most of the cataract surgeons, as nowadays does under topical anesthesia, there is a lot of eye movement continuously and drifting of the head little bit from side to side. And so it requires frequent recentration, because what I felt that the view when the eye is at center is best, and there is little margin of error with the, like it's not same as that conventional microscope. So you have to be exactly at the center to get the best view. The other thing, the first surgery that I did, what we used to do is we used to fix up the microscope first and then set the table. So here I did that, and the table went so low. So this was the understanding for me, that first we have to set the table height at my hands level and then set the microscope height, because I don't have to put it in alignment with my eyes. So in conclusion, I would like to say that the learning curve is not that long. It takes usually 3 to 5 cases to get accustomed to all the change dynamics and position. And we did not observe any significant lag time. But what all the speakers are saying, that there needs to be little less movement with the fine focus. But in our center, what most of the surgeons are feeling, that we have to focus more rather than the conventional microscope. And in future, what we would expect is that the monitor should be wireless, so that when we are moving, we don't have to take all that wires, and movement of the monitor can be minimized in some way. And one other thing, that for any technologies to sustain, the cost is a big issue. So I'm sure in future this is going to come down. The best thing is that all the OR staff fellows are on board. They are seeing whatever I am seeing. And we have like 36 surgeons, and all of the surgeons have tried it, and all of them are just excited to use it, and they are doing very well. So what I request, that we can sit back and rest